Welcome back to SurgiSmart Cut to the Core podcast, where we break down essential surgical topics to help you understand surgical conditions.
Hmm.
I'm your host, Major Munish Chauhan, a general surgery registrar in the British Army and Oxford Deanery. I'm also a senior research fellow at the Center for Army Leadership. If you find these topics valuable, feel free to connect with me on LinkedIn. Today, we're diving deep into Gastro-Oesophageal Reflux Disease, or GORD.
Okay.
Now, this isn't just a common topic on the FRCS exam. It's something that affects millions of people worldwide.
Right.
So whether you're a surgical professional or just someone wanting to understand their own health,
Yeah.
this deep dive is for you. We've got some surprising facts lined up. Did you know GORD can mimic asthma,
Yeah,
or that a tiny magnetic device can be used to treat it?
that's right. GORD can be quite the chameleon, and the advancements in its management are truly remarkable. Let's start by unpacking how this all begins. GORD often stems from a dysfunction in the lower esophageal sphincter, or LES. Think of it as a gatekeeper between your esophagus and stomach, ensuring that stomach acid stays put. But when the LES malfunctions, this barrier weakens, allowing acid to reflux back up.
So even when I'm not eating, there's still a chance of reflux.
Yes.
I've heard the term transient LES relaxations, or TLESRs. What exactly are those?
Those are the sneak attacks that let acid escape, even when you aren't eating. Essentially, these are brief, inappropriate relaxations of the LES. And a number of factors can weaken the LES, making it easier for acid to reflux, including things like obesity, smoking, and even some medications like calcium channel blockers.
Okay, so it's like the LES is under constant pressure and certain things make it more vulnerable. That makes me think about posture. I've always wondered why lying down after a big meal seems to trigger heartburn.
That's a great observation. When you lie down, gravity no longer helps keep stomach contents down, making it much easier for acid to reflux back up, especially if your LES is already weak.
That makes a lot of sense. Now let's talk about hiatal hernias. How do they fit into all of this?
A hiatal hernia happens when a portion of your stomach pushes upward through the diaphragm into your chest cavity. You can picture it like a balloon squeezing into another room through a hole in the wall. This can disrupt the LES's normal function and significantly increase the risk of reflux.
So it's almost like the stomach is trying to escape.
It does sound a bit dramatic, but you get the idea. Now, there are two main types of hiatal hernias: sliding and paraesophageal.
Right.
The sliding hernia, which is more common, involves the gastro-esophageal junction sliding up above the diaphragm. A paraesophageal hernia, on the other hand, is when a part of the stomach pushes up alongside the esophagus. While less common, this type can actually be more serious.
Why is the paraesophageal hernia more worrisome?
A paraesophageal hernia has the potential to lead to complications like strangulation of the stomach, a condition that would require urgent surgery. But it's important to remember that not everyone with a hiatal hernia will develop G or SIT.
That's good to know. So while a hiatal hernia is a risk factor, it doesn't always cause symptoms. Let's move on to acid reflux itself. It's obviously more than just a burning sensation, right?
Absolutely. Prolonged exposure to stomach acid can wreak havoc on your esophagus. Initially, it can cause esophagitis, which is inflammation of the esophagus, and over time, it can even lead to a condition called Barrett's esophagus.
Barrett's esophagus sounds serious. How does that happen?
The Barrett's esophagus is a precancerous condition where the lining of the esophagus undergoes changes due to chronic acid exposure. This highlights just how important it is to effectively manage G or D to prevent such complications. It's not just about the amount of acid that refluxes, but also the duration of its contact with the esophagus. We call this impaired esophageal clearance.
So if my esophagus isn't clearing the acid quickly enough, it leads to more damage. Earlier, we discussed how obesity can weaken the LES. I imagine it plays an even bigger role in GORD.
It does. Excess weight increases pressure on the stomach, making reflux more likely. Imagine squeezing a tube of toothpaste. The pressure forces the contents out. In this case, the contents are stomach acid.
So it's a vicious cycle.
Yeah.
Obesity weakens the LES, then the increased pressure makes reflux even worse.
Right.
But there's some good news here, right? Losing weight can help break that cycle.
Absolutely. Weight loss is one of the most effective lifestyle changes you can make to improve GUDAD symptoms.
That's encouraging. But the complications of GUDAD can extend beyond the esophagus.
Yeah.
What are some of the long-term consequences we should be aware of?
Unfortunately, untreated GORD can have far-reaching consequences beyond the esophagus. We've talked about Barrett's esophagus, but it can also lead to ulcers strictures, which is a narrowing of the esophagus, and even respiratory problems like asthma.
Wow, I didn't realize it could affect so many different systems.
Yeah.
What are some of the red flags people should watch out for? the signs that things might be more serious.
Difficulty swallowing, unexplained weight loss, and vomiting blood are all serious signs that warrant immediate medical attention.
It sounds like diagnosing GORD involves more than just considering the obvious symptoms. How do doctors approach this?
It starts with a discussion about your symptoms, of course, but to get a clearer picture, doctors might use a procedure called endoscopy. This allows them to visually examine your esophagus.
So endoscopy allows doctors to see inside the esophagus. That's pretty amazing.
It is. It's like getting a first-hand look inside your own body. But beyond the visual clues from an endoscopy, there are also functional tests like pH monitoring and manometry. These tests go further by measuring things like the acidity levels in your esophagus and the pressure of your LES.
So those tests help pinpoint what's really going on beyond just what the doctor can see.
Right.
That makes sense. What about treating GRA? What can people do to manage it?
Well, lifestyle modifications are often the first line of defense. Simple things like losing weight, avoiding trigger foods like spicy or fatty meals, elevating the head of your bed, and eating smaller, more frequent meals can make a big difference.
So these changes are all about reducing pressure on the LES and minimizing the chances of acid reflux.
Exactly. And these changes aren't just about symptom relief. They play a vital role in preventing long-term complications as well.
But what if lifestyle changes aren't enough? What about medications?
When lifestyle changes alone aren't enough, there are two main types of medications used for GORD: PPIs, or proton pump inhibitors, and H2 blockers.
I've heard of PPIs. How do they work? What are they actually doing in my stomach?
PPIs act like a stop sign for acid production. They block the proton pump in the stomach, which is responsible for secreting acid. This reduces the acidity of your stomach contents, making them less irritating if they do reflux.
So they're getting to the root of the problem by reducing the amount of acid in the first place. What about H2 blockers? How do they work?
H2 blockers also reduce acid production, but through a different mechanism. They block the action of histamine, a chemical that stimulates acid secretion.
So in a way, they're like a backup system working alongside the PPIs.
You could say that. They're not as potent as PPIs, but they can be effective for milder cases of DRD or for individuals who can't take PPIs for various reasons. But it's important to be aware that long-term use of PPIs can have potential side effects.
That's a bit concerning. If I'm relying on PPIs for a long time, what kind of risks am I looking at?
Some potential risks associated with prolonged PPI use include bone fractures, vitamin B12 deficiency, and even an increased risk of certain infections. That's why it's always essential to discuss the risks and benefits with your doctor.
So it's all about finding that balance between the benefits of acid suppression and the potential risks of long-term use. What about surgery? When does that become an option in managing GRD?
Surgery is typically considered a last resort when medical therapy fails to control symptoms or when complications arise. The most common surgical procedure for GRD is called fundoplication.
Fundoplication. What does that involve? What are they actually doing during this procedure?
It involves the surgeon wrapping the upper part of your stomach around the lower esophagus. This strengthens the LES and helps prevent reflux. It's essentially like creating a tighter seal.
So it's a pretty major surgery then.
It is considered major surgery, but it can be very effective. There are different techniques for performing a fundoplication, but they all revolve around the principle of reinforcing the LES to prevent reflux.
So the surgeon chooses the specific technique based on each individual case.
Exactly. The surgeon will consider factors like the severity of your GORD, the presence of a hiatal hernia, and your overall health when deciding on the best approach. But like any surgery, fundoplication carries risks such as infection bleeding and difficulty swallowing. There's also a chance the wrap could loosen over time, requiring further surgery.
That's something to consider carefully. It sounds like it's not a decision to be taken lightly. Are there any other surgical options besides fundoplication? Something less invasive, perhaps?
There is a newer, minimally invasive procedure called the LINX device.
The LINX device. That sounds interesting. What is it exactly?
It's a small band of magnetic beads that gets implanted around the LES. The magnetic attraction between the beads helps strengthen the LES and prevent reflux.
So it's like a magnetic reinforcement for the LES. That's pretty ingenious. What are the advantages of this approach?
One of the main advantages of the LINX device is that it's reversible. If there are complications or if it's no longer needed, the device can be removed.
That's reassuring to know. But I imagine it must have its limitations too, right? It can't be suitable for everyone.
You're right. The LINX device isn't suitable for everyone. For instance, it's not recommended for people with large hiatal hernias.
So both fundoplication and the LINX device offer potential solutions, but they come with their own set of considerations. Shifting gears a bit, Let's talk about the clinical presentation of USARID. I know heartburn is a classic symptom, but what other signs should people be aware of?
You're right, heartburn is the hallmark symptom. It's that burning sensation in the chest that often occurs after meals or when lying down. This happens when stomach acid flows back up into the esophagus. And then there's acid regurgitation, where you actually paste the acid in your mouth.
Like acid regurgitation. That's another telltale sign. But I imagine GORD can be a bit sneaky sometimes, presenting with less obvious symptoms that might be mistaken for something else.
Exactly.
Yeah.
GORD can be quite deceptive, and it can manifest with symptoms that you might not immediately connect to acid reflux. For example, some individuals experience a persistent cough or hoarseness.
A call for hoarseness. That's interesting. How is that related to GORD?
This can occur when stomach acid irritates the vocal cords or even ends up being aspirated into the lungs, so the symptoms aren't always confined to the digestive system.
So GORD can actually have respiratory manifestations as well. That would make it really tricky to diagnose.
It can. That's why a thorough medical history and physical exam are so crucial in the diagnostic process. In addition to those, doctors may use tests like endoscopy pH monitoring or manometry to confirm the diagnosis.
We talked about endoscopy earlier, but what about these other tests? pH monitoring and manometry, what kind of information do they provide?
pH monitoring measures the acidity levels in your esophagus over a 24-hour period. This helps determine how often and how severely acid is refluxing.
So it's like a log of your esophagus's acid exposure throughout the day and night.
That's a great way to put it. And manometry measures the pressure and muscle activity of your esophagus and LES. It helps evaluate how well they are functioning and whether there are any motility issues that might be contributing to your symptoms.
So these tests provide valuable insights beyond just the visual inspection of an endoscopy. It's a much more comprehensive approach. Speaking of diagnosis, when is it necessary to involve a specialist? At what point should someone seek expert help?
That's a good question. Most cases of GORD can be managed effectively in primary care. However, if your symptoms are severe or don't respond to initial treatment, a referral to a gastroenterologist is warranted. They can perform further investigations and recommend more specialized treatment options.
And what kind of specialized treatment options are we talking about here?
Well, apart from the lifestyle changes and medications we've already discussed, surgery is a possibility for select cases. As we mentioned earlier, fundoplication is a common surgical approach.
Right, where the stomach is wrapped around the esophagus to reinforce the LES, and then there's the LINX device as a less invasive option.
Exactly. The LINX device is a promising alternative for some patients, offering a less invasive way to address GORD.
So managing GORD really is a multifaceted approach that can involve lifestyle changes, medications, and in some cases, surgery. It's about finding the right combination of tools to address each individual's needs.
That's a great summary. The key is to find the right balance of treatments to control your symptoms and prevent those long-term complications we talked about earlier. It's about taking a proactive approach to managing your health.
Before we wrap up this deep dive into GoDog, I'm curious about the challenges you face when treating patients. What are some of the most common hurdles you encounter?
That's a thoughtful question. One of the biggest challenges we face is managing patients who don't respond to standard PPI therapy. We refer to them as PPI non-responders.
That sounds frustrating. Why don't they respond to the PPIs? Is there something else going on?
There could be several reasons for this lack of response. Some individuals might have a different underlying conditions, such as functional dyspepsia, which doesn't involve acid reflux. Others might not be taking the medication correctly or may have developed a tolerance to it. It's like solving a puzzle.
So you have to do a bit of detective work to figure out the underlying cause and the best way to manage it.
It can be quite a process. We might need to adjust their medications, try a different class of drugs, or consider further investigations like pH monitoring or endoscopy to reevaluate the diagnosis. And then there's the challenge of long-term PPI use, which we discussed earlier.
Right, finding that balance between the benefits of acid suppression and the potential risks that can come with prolonged use. It's a delicate balance to strike.
It is. We strive to prescribe PPIs at the lowest effective dose for the shortest duration necessary. We also educate patients about the potential risks and monitor them closely for any adverse effects.
And then, of course, there's patient adherence to therapy, which I imagine can be a significant obstacle. It's one thing to discuss lifestyle changes, but actually Implementing them can be tough.
Absolutely. Lifestyle changes can be challenging to maintain, and taking medications consistently, especially over the long term, can be difficult for some people. It requires a real commitment to change.
So it's important to have open communication with your patients, understand their barriers, and support them in making sustainable changes.
Absolutely. We work closely with our patients to understand their concerns, address any barriers to treatment, and empower them to take an active role in managing their health.
Well, this has been an incredibly insightful deep dive into GORD. We've covered so much ground from the underlying mechanisms to the various presentations, diagnostic approaches, and treatment options.
I agree. It's been a pleasure sharing my knowledge and insights on this topic.
Before we move on, I want to leave our listeners with a thought-provoking question. If you were experiencing any of the red flags we discussed earlier, like difficulty swallowing, unexplained weight loss, or vomiting blood, how quickly would you seek medical advice?
That's a crucial question. Those red flags should never be ignored. It's essential to seek medical attention promptly if you experience any of them. It could be a sign of something more serious that requires immediate attention.
Those are definitely warning signs that shouldn't be taken lightly. Now, to bring all of this to life, let's move on to a case study that illustrates these concepts in a practical setting. Welcome back to Surgeon Smart Cut to the Core. Let's put our GORD knowledge to the test with a case study. Are you ready to dive in?
Absolutely. I'm ready when you are. Case studies are a great way to bring everything together.
All right, so let's meet our patient. He's a 55-year-old male who comes to us with a 5-year history of heartburn and regurgitation.
Okay.
He describes the heartburn as a burning sensation in his chest, especially after meals and when lying down. He also experiences occasional acid regurgitation, particularly at night. He's tried over-the-counter antacids, which provide some temporary relief, but those symptoms always seem to return.
That's a very typical presentation for GORD. It sounds like he's been struggling with this for quite some time. What about his lifestyle? Are there any factors that might be contributing to his symptoms?
He's slightly overweight, enjoys spicy food, and tends to eat his dinners late. He also smokes about a pack of cigarettes a day.
Okay, so we've got some lifestyle factors that could definitely be playing a role here.
Yeah.
The weight, the spicy food, the late dinners, and the smoking, those are all things we can potentially modify. What about any other medical history or medications?
He doesn't have any other significant medical conditions and isn't taking any regular medications.
So based on his symptoms and history, GORD is certainly high on the list of possibilities. What would be the next steps in evaluating this patient? How do we move forward with investigating his symptoms?
Considering his symptoms have persisted despite using antacids, I think it's time to step up our investigation. A trial of a PPI seems like a logical next step. Wouldn't you agree?
I completely agree. A PPI would not only help us manage his symptoms, but also provide valuable information about whether acid suppression is effective for him. If his symptoms significantly improve on a PPI, it further supports our suspicion of GORD.
Okay, so we start him on a PPI. What other investigations would you consider at this stage? What else can we do to get a clearer picture?
An endoscopy would be helpful at this point. It would allow us to visualize the esophagus and stomach lining. This will help us rule out any complications like esophagitis or Barrett's esophagus, especially considering his long-standing symptoms and smoking history.
That makes sense. We want to be thorough and rule out those more serious possibilities. Let's say the endoscopy reveals mild esophagitis, but thankfully no signs of Barrett's esophagus. His symptoms also show significant improvement while he's on the PPI. So we're feeling confident about the diagnosis of GORD. What's our long-term management strategy for this patient?
We need to address those modifiable risk factors we discussed earlier. It's crucial to counsel him on the importance of weight loss, quitting smoking, avoiding those trigger foods that seem to worsen his symptoms, and adjusting his eating habits.
Right. Lifestyle modifications are fundamental to managing GORD effectively. But what about the PPIs? Will he need to stay on them indefinitely?
Not necessarily. We can explore stepping down his PPI dose once his symptoms are well controlled and see how he does. The goal is to find the lowest effective dose that provides him with sustained relief.
So it's about finding that balance between managing his symptoms and minimizing any potential long-term risks associated with PPI use. But what if those lifestyle changes and intermittent PPI use aren't enough to control his symptoms? What are our other options?
If he continues to experience troublesome symptoms despite these measures, we could consider surgical options.
Like a fund duplication? Is that something we would consider for this patient?
Exactly. A laparoscopic Nissen fundoplication could be an option if he meets the criteria and is willing to consider surgery. It's a minimally invasive approach that has proven to be effective for many patients.
But we also have the LANX device as a less invasive alternative, right? Would that be a potential option for him as well?
Yes, the LINX device could be a good fit for him, especially if he's concerned about the potential side effects of a fundoplication, like gas bloat syndrome. It's a less invasive procedure with a generally quicker recovery time.
So we've got a range of options at our disposal, from lifestyle modifications and medications to surgical interventions. How do we go about deciding which path is best for this particular patient?
It all comes down to shared decision-making. We need to engage in an open and honest conversation with the patient, discussing the risks and benefits of each option. We need to take into account his preferences, his lifestyle, and his overall health. It's about finding the best fit for him as an individual.
That patient-centered approach is so important. It empowers patients to make informed decisions about their own health. It's not just about telling them what to do, it's about collaborating and finding the best path forward together.
I couldn't agree more. It's a partnership between the doctor and the patient.
This case study has really highlighted the complexities of GOR management and the importance of a tailored approach. What are your final takeaways for our listeners?
GORD is a common condition, but it's important to remember that it's more than just heartburn. It can significantly impact your quality of life, and it's crucial to be proactive in preventing those long-term complications we discussed.
It sounds like early intervention and open communication with your doctor are key. To our listeners out there, if you're experiencing symptoms, don't hesitate to talk to your doctor. GRD is treatable, and understanding your options is the first step towards effective management.
Absolutely. Knowledge is power, and we're here to help you navigate those choices.
Thank you for joining us on SurgiSmart Cut to the Core for this deep dive into GORD. Until next time, stay curious, stay informed, and stay healthy.